Hi, everyone. Thank you so much for tuning in today. We're really excited to bring you an amazing lineup of thinkers today and a conversation about a really critical question. What is the future health workforce we need? Let me start by introducing myself. My name is Alicia Bagat. I'm the host of today's conversation. In my day-to-day, I work with Forum for the Future, and I collaborate with global teams applying futures and systems thinking to tackle complex challenges. Part of this work includes projects with the Future Center, a participatory digital platform for tracking trends and signals of change, making sense of what's emerging in the world, and building communities to drive positive change across key sustainability and social challenges. This particular project is really fascinating in that the Future Center has partnered with the Johnson & Johnson Center for Health Worker Innovation on a project that aims to build a shared understanding of how COVID has impacted society and distill learnings about what that means for how we design, build, and run more resilient community health models in the future. We're running a series of dialogues across 6 key questions, which we feel are fundamental to transforming community care models and thinking differently about health systems more broadly. You can find out more about these inquiries on thefuturecenter.org. So it's www.thefuturecenter.org. Let's start by introducing today's speakers. So today's conversation around the future the future health workforce that we need. I'm joined by 3 amazing guests, each of whom approaches this question from a slightly different angle through their work. I'm going to let them introduce themselves and say a few words about their work. They were all asked to choose an image which to them personally exemplifies the health system of the future. So I'm going to ask each of you to share your image when you introduce yourselves and tell us why your image was the one that was chosen. So let's start with Sandeep.
Thank you. Hello, everybody. My name is Sandeep Kapila. I come from Mumbai, India, and I'm happy to represent an organization, Swasth Foundation, which is an action, research, and training not-for-profit based out of Mumbai. Our focus is to create an integrated health ecosystem with joy for everybody. And what you see out here is the image as how we visualize this health ecosystem. We couldn't find a better example than nature to model an ecosystem where we have all the different kinds, the variety, the trees that are represented, different species blossoming themselves, showing their own self in completeness, and yet being distinct in their own way. So just like a health ecosystem where there are different components, different kinds of services, and we are not limited as we are today by just possibly medicine, surgery, some of these modalities, but really expanding and looking at new modalities, which are of course evidence-based and have impact as well. The water and soil of this ecosystem to us is the values, which are very essential to health, because health while it can be a business, but it also is about lives. So how do we create these values and continue working with these values at all times? The roots of each one of these which come are the support teams, that is needed for these trees to blossom, right? Be it accounts, payroll, sort of the information technology, the boring stuff in some ways, but also exciting for many. The sun, which is our source of energy, is the financiers, and the environment is the culture. And we have these cross-pollinators, somewhat like we have Alicia from the Forum for Future. They are pollinating from one to the other. There is an exchange of ideas, and the system works where people come, they can choose what they want and stay healthy. The ultimate vision being health and joy for all. So that's our vision, and that's how we see the health ecosystem of the future. Thank you.
That's great. Thank you. Khama, would you like to share?
My name is Khama Rogo. I'm addressing you from Kisumu, Kenya. That's a small town on the shores of Lake Victoria. You may know that Lake Victoria is the second largest freshwater lake in the world after Lake Superior. My choice is the giraffe. And there is a reason why the giraffe has survived in the African savanna. You may not know, but the giraffe is actually a goat. It belongs to the goat family, but it's a goat with a long neck and long legs. And this has been an evolution that has made it possible for this gracious animal to survive in the jungle, where you have all those carnivores. The giraffe is a herbivore, so it doesn't eat meat, it eats leaves and it eats grass. But that long neck is what has made it survive, because it can see very, very far in the flat African savanna, where you have grass and shrubs and not very long trees. And being able to see far gives you foresight. And in the jungle, foresight is more important than hindsight, because you never leave hindsight if you don't have foresight. And I therefore like the giraffe, because in the subject that we are tackling today, which is a health workforce of the future, we need, first of all, to see the future. But most important, before we even talk of the future, we must be able to survive today. And this animal gracefully has shown us that it has survived from just being another goat, and it can see extremely far. But even when it does so, the giraffe is probably at its worst risk when it is thirsty and wants to drink water, because getting that neck down on the ground into a water is an extremely difficult adventure, because it has to push its 4 legs apart, then bring the neck down. And because it is a slow process, that is when it is most vulnerable, because a leopard or a lion could quite easily jump on its neck, catch the jugular, and kill it. The giraffe's biggest defense is on its hind leg, because it can kick. But when it is down to drink, because the 4 legs are wide apart, it is unable to kick. And this, to me, is an important thing, that important as health workforce is, we have not been able to kick into place the necessary interventions to make it work for now and to work for the future. I'll explain this a little bit further, but if you remember nothing, remember my beautiful giraffe sitting in my beautiful country of Kenya.
Thank you so much. That was lovely. Denise.
Yes, so good morning, everyone. I bring you greetings from Connecticut on the eastern coast of the United States. I want to just begin my comments by acknowledging and recognizing the many frontline workers, and particularly community health workers, promotoras de salud, community health representatives, and many other CHWs around the globe who lost their lives during this pandemic and who have been on the front lines of incredible trauma, exhaustion, illness, and structural racism and challenge during this global pandemic. I want to begin my comments by saying that as a community health worker, I envision a culture of health where all individuals, but in particular community health workers, have self-determination and dignity, where communities meaningfully contribute to system co-design and governance of those systems, and where societies eliminate structural barriers to well-being. Here in the United States, in the early months of COVID-19, our US Department of Homeland Security actually classified community health workers as essential critical infrastructure workers and recommended that they be paid to respond to the pandemic. However, during that very same time, in the early months of the pandemic, many of my peers, colleagues, and mentors, CHWs across the country, were being laid off from medical or public health environments. And those who worked in community-based organizations were struggling to have their voices, their leadership, and the culturally relevant strategies that could help protect communities from COVID-19 be integrated into our COVID response. So we know that up to 80% of what impacts health happens outside of a doctor's office, outside of medical treatment or a prescription. It is what we have come to know as the social drivers of well-being or the social determinants of health. So we have to elevate all workers. And the slide, the image that I wanted to share with you is bringing that urgent demand forward, that we must elevate all workers, especially community health workers, who center community-sourced expertise with compassion and respect for all people, and eliminate the barriers to the social drivers of well-being. This image represents a future vision where all frontline workers who contribute to health and well-being by cleaning our streets, by helping us have safe and affordable housing, by making sure that we have nutritious food accessible to us, clean water, et cetera. But in particular, community health workers are respected with a thriving wage and an appropriate workload, where they are protected with benefits and access to self-care, and where they are authentically partnered with to achieve community health and well-being. And I just want to thank you so much for having me.
Thank you so much, Denise. So before we get into it, I will just introduce for our audience the 3 Horizons process and the Miro board that they're going to be, that they just saw and that they'll be seeing occasionally during this segment. So I want to cover a few logistical points about how we're going to run things today. For those of you who have tuned in to prior conversations, this will be a refresher. The first thing is to introduce the 3 Horizons framework, which is the framework we will be using to structure the conversations today. This 3 Horizons framework is really just a framework for structured thinking about the future, and it's about transformation. So it's premised, as the name suggests, that there are 3 horizons that are playing out at the same time, but each containing seeds of the future. So this is all kind of happening at once. The x-axis tracks time, the y-axis tracks prevalence. The first horizon that we see, you can see the horizon 1, is the status quo. This describes the current context and conditions, working assumptions, the dominant paradigm, and not all of the ideas, practices, and concepts on the first horizon are fit for the future. So not everything in the current status quo is future fit, basically. So, which is why you see that line curving down as time goes on. The first horizon is what is dominant today, but what is in decline over a long-term time period. The third horizon, on the other side, describes the future that we want. And thank you, Denise, for sharing that vision. The seeds of the future are very much present and visible today. It's often what we describe as new trends, emerging innovations. These are things that might be weak signals of the future today, but if they grow and they become mainstream, they can come to form a new paradigm. So in the future, the third horizon will replace the first horizon. And then the most interesting horizon for us is perhaps the second horizon, which is the space of disruptive innovation. So this is new ways of doing and being, a space of change between Horizon 1 and Horizon 3. The second thing I would like to mention is the Miro board, which many of you are familiar with. are kind of like an online whiteboard, and they basically are great for digital and visual collaboration, running online workshops, something we've had to do a lot of in the pandemic. So we have this for this entire series of dialogues, and we're going to be capturing the insights across the 3 horizons, allowing us to visually categorize how people and how our experts today are diagnosing the status quo, what they are seeing as a better vision for community care and for healthcare workers, and what they think the key leverage points are with regards to transformation that will help us create a bridge between the present status quo and the preferred future. So it is a living tool. We will be sharing it on the Future Center, and where you as the audience can comment on and add your thoughts. So we'll also be a participatory tool for ideas exchange about these topics. So let's get into it. And let's talk about the status quo and kind of the business of usual today. So during the COVID-19 pandemic, there's been a huge focus on the role of health workers, and more specifically in some areas, community health workers in society. There's a great discussion on how we train, compensate, value community health workers. But at the same time, we face an overall health worker shortage and burnout. By some estimates, this could be up to 8 million healthcare workers globally that by the end of the decade will be needed to fill the gap in demand. So I'd love to know how all of this, all of these things kind of play out in what you all are seeing in the healthcare system right now, and sort of what are the dominant paradigms? What is kind of our business as usual when it comes to the healthcare system vis-a-vis workers within it? So anyone can start.
Can you hear me? The COVID situation is one that most of us, and definitely most of you who are in a developed world, never thought would happen, not with the speed and intensity with which it has happened. The health workforce debate is one that has been going on for a long time, but one in which no government, no international organization wanted to take ownership. And for good reasons too. One is that it is just one of the 6 building blocks of health systems, according to WHO. And it's probably one of the more difficult. So people go for the soft targets, which the other 5 happen to. 2 is that it is a long-term investment. It's not like putting money into a vaccine or into a medicine or into intervention. And most people don't want long-term things because the kind of fundings we have nowadays globally are short-term. The politician wants quick results and the NGO wants quick results. It's all 5 years and it's done and you're gone. And third is that it is complex because unlike, say, education, where the workforce consists largely of a teacher, in health, you have multiple specialties and skills that are needed. So although the most ubiquitous skilled health worker is the nurse globally, outside of the large skills, there is even more. And even the nurse can't do it on her own, neither can the physician or everybody. So when we talk about this workforce, our biggest headaches has been to define the range of skills that are required in this workforce. And 2, the balance of those skills so that it suffices in creating the necessary change that is required. But this has also been challenged by something else, that science and economic development has made it impossible for us to agree on most things that are important to human resource in health. Because the developed world, in a big mistake, had thought that they had gone past the infectious disease era So they were dealing with post-infectious problem, and therefore didn't have to deal with anything like malaria, like viruses and so on. And then COVID comes and is one of the simplest viruses. And all of a sudden we find that what we were planning for, non-communicable diseases, post-infectious, those plans can't work when you're dealing with an infectious disease. So in looking at this area, I would like us to be mindful of two things. That is it the workforce that drives the future of healthcare? Or is it the future healthcare that drives the type of workforce that we want? It would appear that we are not decided on this globally, and that creates a problem because you end up training a lot of people who may not be useful where they are and therefore have to move. And this is why there is so much migration of health workers. But the basic health structure that we want, the basic where the community health worker is required, is often not recognized by the system. So in a lot of our countries, you'll find that the CHW is a volunteer, is not salaried, and is expected to deliver something that is not quantified. This is the conundrum in which we find ourselves in at this particular time. Thank you.
Well, I'll jump in and thank Dr. Khama for his comments, and it's very nice to meet both of you. I pray that all is well with you and with your families and your communities. I just want to go back to my earlier comments and level set a unique context in the United States. And I didn't say this, but I think it's important that when I talk about community health workers in the US, these are very different models than what I see in many countries around the globe. The majority of community health workers in the United States do not work with or under a nurse or a medical doctor. They do not work in hospitals. They don't work in medical clinics, and they don't provide clinic-based services, immunizations, this sort of thing. The majority of community health workers in the United States are focused on upstream sort of preventable disease, what we would call social services, behavioral health services, or the social drivers of well-being. And I just want to dig a little deeper into sort of that orientation and describe it a little bit and its challenges, Alicia, as you talk about the sort of gap and the need for a future healthcare workforce. The first level set that I think is very important in a US context is that the disparities that we see in healthcare access, healthcare quality, healthcare status, and outcomes are built in to the United States infrastructure in a systemic and a political way since its colonial period. You cannot separate disparity in health status and outcomes in the United States without looking at the founding of the US. And so I'll summarize those statements by saying these systems were not built and designed for the health and well-being of indigenous populations or enslaved Africans who were brought here to the United States. So the hundreds of years that we have in sort of these gaps, they are persistent because of the infrastructure itself. Suffice to say, you cannot begin to chip away at eliminating disparity in health status, healthcare access, or health outcomes without addressing systemic racism in the United States. The other reason that that's important is because in the US, community health workers have evolved and have come to the fore within those inequities. In other words, the majority of CHWs are women. The majority of CHWs in the United States are persons of color, immigrant, refugee individuals, descendants of enslaved Africans, descendants of indigenous populations in the US. And so many of us experience the same inequities. Many of us live with chronic disease. We are people from the reentry community. In other words, we were formerly incarcerated. We're persons living with HIV. We're persons who have suffered a fetal or infant death. We're persons who experience those same barriers, which is why we are able to build across silos and sectors that exist in the US, because in a very sense, we are survivors. Right? We come from communities of inequity, and we build bridges and develop advocacy and strategies that are locally sourced to address these inequitable systems. The last point that I want to make is about sort of the gap in the future healthcare workforce. And I've heard that globally, folks have said, oh, we need 18 million or so community health workers. I'm not quite sure where that data is coming from, because the questions I would ask are, you need CHWs to do what, where, with whom, and in what communities, right? And for what goals? But what I think is important is that in the United States, we do not have a recognition of community health workers as actual public health professionals. We're some of the lowest paid. To Dr. Khama's points, the majority of us still are funded through short-term grant programs. There is no sustainability model in terms of a financing infrastructure in the United States. And it's only emerging that the federal government is actually even recognizing us as a real profession here in the US. So if we're going to address some of those gaps, and again, we know that most of the focus and the investment must be on prevention, not downstream medical treatments or prescription drugs, but we actually need to go upstream and into community. We have a lot to do here in the US to create that continuum.
Thank you, Denise, for that, because you sort of started the dialogue on how health is just more than what we see sometimes today, the social determinants of health, and how so many other things impact health. And I think the context of what a future health system has to bring that into light in a much, much more stronger way, because the current healthcare system that we see is so much focused on just treatment. And I think what the COVID pandemic actually showed to us was just the importance of this, right? The bigger impact of the pandemic has been the lockdown, right? Because, or where disruptions were happening because people didn't comply or didn't understand the need for social distancing, etc., basic COVID appropriate behavior. So it wasn't the science which necessarily failed us, but it is the social side, which also resulted in very, very big impact on what happened, or the impact of the negative impact of the pandemic was there. So I think any healthcare system or health system that we think of for the future has to bring these two together somehow, the social side and the science side. And right now, what we see oftentimes, they are at odds with each other, right? So there is a big fight in some ways that's going on for different reasons. Each has their own thought process and agenda. And I think that integration is key. To me, that also indicates that the future health workforce has to have people who can do this integration, right? Otherwise, we need the specialist, we need the social specialist who can look at the social side, we need the people of science, but we need this integrated care professional also who can bring these different aspects of science and society together, and also different modalities of healing. Because each society, the indigenous, I'm sure in the US, the Africa, I know in India, definitely, we have so much tradition, so much history on healing, which goes way beyond what the modern medicine and surgery can do. And to me, that's the key important, another piece that has to be looked at for in the future. How do we bring these two aspects together? How do we bring in the different modalities, the richness of the heritage of various cultures together, integrated with the modern science? It's not about either or, it's the and that is important.
Yeah. That's great. And I think just building on that and the integration that's needed, what do you see as kind of working well that we could build on for the future? So whether it's systems or practices that are already kind of in place today that you see as really working well and kind of worthy of pulling into the future.
The biggest challenge that we have, Alicia, in addressing health challenges is that the thinking is driven from a very, very small geographical area of the world. And the thinking of global health is driven by resources. So countries that have more money have a bigger voice in trying to give directions to where the world ought to be, whether it is through the United Nations, WHO, or whatever. Countries that have less resources, that are dealing with the basic burden of disease, do not have a voice there. And you can bring this then to the national level too, that even at the national level, those inequities are enhanced. And I think that is what Denise was talking about in the US, that you have communities that do not have resources, and they all suffer the same gaps in healthcare delivery and health outcomes as they would in India, as they would in Kenya. So the very, very fact that we've driven health delivery and health discussion to a corner where it is determined by resources in itself skews our view of what the future of healthcare ought to look like. And for so long as we have that skewed look at that, we are unable then to create the health workforce for a future that is different from the skewed one that we have. So let us look at the role of community health workers. We know that health starts with the individual, it's in the family, and it is in the community. By the time it reaches the hospital, there is no health anymore, it is lack of health. So how much are we willing to invest in this area rather than invest in the brick and mortar, the technology and everything that takes care of you when the individual, the family, and the community fails? Now, if we look at the way we judge good healthcare services, we don't judge good healthcare services by what happens at those lower areas. Globally, it is judged by what happens in the clinic upwards. So you start looking at the metrics, that it is the number of nurses per population, the number of doctors per population, the number of hospital beds per population. And those ones then start driving the expenditure, the investment. Nobody wants to come back to the basics of primary health care, where you may not require all those 5-year, 10-year degree skills, but you'll impact much, much more on the health of a bigger proportion of the population than the other. And I think that this is where we have a major, major problem, that health for who, by who, and for what purpose. You will find, for example, that during this COVID pandemic, all countries have had a problem defining who's the frontline worker, who is the frontline health worker. And we've moved from country to country, and we found that people can't even define who it is. Because we want to lock down, we find that the policemen and the security forces are sometimes more frontline than the highly skilled specialists who's sitting in an intensive care unit. So how do you handle this? Because the definition keeps changing depending on what you're dealing with. But the most important thing is the world serious about primary health care? Because that is where we should have our agreement. Everything else we can disagree on. And if we agreed on that and put resources and our minds to making things work at that level, then I think that everybody would start finding their space and health would be extremely avoidable. Why, for example, even if we talk of non-communicable diseases, have we seen in the West, in the US and elsewhere, major growth in gyms and health spas and so on? Because people want to do exercises so that they don't get high blood pressure and the blood sugar is low. But when COVID comes, you find that crowding in the gyms has to be forbidden And all of a sudden, we find that gyms are actually could be irrelevant under those circumstances. And you can just walk outside and on your own and breathe fresh air, and you'll be as physically fit as everything else. So these to me are the areas where we don't seem as a human race to come to the same thinking on what needs to be done. Where should our priorities be in creating the future health workforce? Is it in that highly specialized person who will change the valve in the heart? Or is it in the community health worker who will stop the bacterial infection that eventually can turn into a heart valve defect? These are all arguments, but unfortunately, they have been driven off the table by our wish to claim that we have the latest technology and we have the latest medicine and we have the latest vaccine.
Yeah, let me just quickly add, I think the United States has a moral imperative to respond to the pandemic and has done so ineffectively. So, you know, whether or not we will do that and become the type of global actor who responds appropriately with resources is yet to be determined. I know there have been many conversations at the federal level and between governments on the role of the United States. But I think that more can be done. So I just want to say that generally speaking. Again, this is not a new issue. This is not a surprise to us that resources are meted out and held inequitably. So this is not specific to the pandemic. It's simply exacerbated by the pandemic. Alicia, I know you asked, you know, sort of what's working well, or so are there sort of bright spots? And I do think, you know, number one, to Dr. Khama's point, in the US, we saw that all of those specialists and folks working perhaps in health systems, but who never really touched community or on the front lines, had to be redeployed and sent out into the community or to the front lines like never before. The United States suffered not only under severe sort of access issues, and there are still many places across the US where access to the vaccine, for instance, access to testing is an issue. We have rural communities that can't have that access. And until we had the type of vaccine that didn't require the super cold storage, we knew we were going to have an access issue. But a lot of medical workers were not used to coming out into community and having that relationship and that communication. I think the other thing that has worked well, but what had not been significantly invested in, was our public health infrastructure. There was not enough integration between medical or clinical services and public health. And what we lacked in the US was an integration, to Sandeep's point, of a medical response, a public health response, and a community-based response. We needed community assets to be brought to bear, community trust, community strategies, language access, language diversity, people who understood what the barriers were and were able to traverse them to integrate with public health professionals around public health messaging, public health behaviors to protect community members until they could get to clinical services and medical services. So we are just now sort of refocusing in the US on that sort of prioritization and resource allocation. In other words, billions of dollars are now being considered to reinvigorate our public health infrastructure. The question remains whether or not this will be sustained in a way that will focus on prevention, or whether we will continue, as Dr. Khama said, to wait until people end up in the emergency room. And now we are addressing the disease state in terms of preventing that state. So all of this is yet to be seen. I think we have some emerging bright spots, but not necessarily there. And then the last thing I want to point out is just going back to the image that you shared about sort of the future and sort of these three intersecting arcs or cycles. My big concern around the H1 and the way in which it is imaged as being something in decline, I think is still very arguable. There is a lot to be said for the fact that existing systems actually drive a lot of capital and income for certain communities, certain corporations. And so I don't know if we have enough critical mass, enough mobilization to actually change these systems. You know, when people are sick, a lot of people make money. And so one of the ways that we're going to change that is to change the way in which we reimburse, change the way in which we measure, change the way in which we govern these systems that are in fact making dollars off of people's poor health status and poor health outcomes.
I was waiting for Sandeep to say something, but if he's still waiting for me, I would be willing to put something on the table.
Hi, can you hear me? I think there's some issue with my internet. So, okay. So I think during this time, there are few things which we saw which were happening good. At least in India, there were some, I would say, positive signs of how things are beginning to change. I think one, we saw that there is trust in the community on these traditional systems still, at least in India, right? The traditional communities, the middle class also of India, there is trust, and there is a certain disillusionment with the sort of current healthcare system, which creates a dependency, right? The current health system is about creating a dependency on the doctor, on the specialist, that on the technology. Right, to Khama's point, it's become a dependent. I need the latest gadget, right, to be healthy. Otherwise, I am not. Or I need the most in fashion gym or most in fashion type of yoga to be healthy now, right? So it's creating a system of dependency, and people see through that. I think that's something we saw during this pandemic, because it exposed the weakness of the existing system to everybody at scale. To us, that's the opportunity in some ways, to tap into the low resource solutions. Again, there we find that there is evidence now, which scientific community accepts. So that's where there is an integration now, right? Where the scientific community is accepting that simple things like the right diet, to Khama's point, the right movement exercises, right? Basic breathing can keep you healthy, and you don't need something very fancy to do that, right? The challenge, as Denise said, is around people will lose money if that starts happening. There are people who will lose money if that really starts happening, and I think hence if the focus can be on how do we do this, and at the same time, our belief is that there will be enough people will still fall ill, or the people who have to make money from people falling ill can continue to do that. But let's not maximize that. There is a solution. There are very simple solutions in all traditions. I think yoga is one, and yoga, the simple yoga, not the complex, fancy yoga that comes out today sometimes. The basic stuff, which can be actually translated at right, simple diet as per the local situation, simple movement, simple breathing, right, and keeping your mind largely sound and joyful, right? So if you are able to just do these 4 basic things, people will stay healthy largely. There is evidence around that now. That to me is the good science. So I would say, the summarize the good science, there is evidence, there is scientific evidence, which is far from, you can't really deny it. And I think there is faith and belief in the community now, because the current system has been exposed quite significantly. There is that desire to look for something new, and I think that's why there is an opportunity right now, really, to tap into that.
Let me, I will have to start moving us into kind of final remarks and things. I know that Khama, you're waiting to say something. I will just sum up a little bit of what I'm hearing from you all, in that a lot of the kind of innovation and disruption that people are looking for in this space seems to be things that are not what people would normally expect when they think of innovation and disruption in terms of like new technology or you know, brand new ways of doing, but rather, you know, traditional systems, things that are already embedded in the community, things that we might know that are less kind of exciting, you know, to your point, Khama, around, you know, making long-term investments in care and thinking deeply about kind of who the care is for, why, primary care, things that are, you know, less exciting to fund than the brick and mortar or the vaccine or the, you know, health technology on your wrist. So I think that that is definitely, you know, a theme that's coming out, that in this conversation, it's less about kind of the specific technology, and it's more about these almost embedded systems practices that people know about, but are perhaps less motivated to elevate to the level that they would need to. And I don't want to say they're not motivated at all, to your point, Sandeep, that they are kind of looking into these traditional systems, but that perhaps in the larger national dialogues or global dialogues, these are not the necessarily elevated interventions that as they should be. So that's what I'm hearing, but I would be interested to hear kind of more on that, and if there is something that you think. So then let's move into the wrap-up portion, and would love to hear any final reflections or thoughts kind of about this topic before we close. And maybe Denise, you can start as you need to drop.
Sure. The biggest challenge for me is the impact of race and identity that it establishes structural barriers, whether that is income barriers, policy barriers, access barriers for people to pursue and achieve their health and well-being. I know that undergirding all of the other conversations about supply chains and resources and expertise and distribution, there is that undercurrent that has impacted the entire globe and literally every nation. So the extent to which every nation can examine the inequities in its own policy, I think we will begin to reconcile with the fact that we have not acted as if we are our brother's keeper, and we have not preferred others greater than ourselves, in particular, those who have less than we do. One of the most exciting things that I have seen, and I want to say that I've been a beneficiary of, is the fact that community health workers around the globe have been coming together to identify what across our nations and our different contexts are similar to us. And what we find, again, is that we are some of the lowest paid. Oftentimes we are not well paid. We do not have health benefits. We often are precarious workers. And so the extent to which we can organize across nations and elevate this workforce, which can help our clinical care and our specialty providers, which can help our public health epidemiologists and specialists, which can help those who are creating life-saving vaccines. And that's what we want to do. We want to draw down the expertise of other professionals and build bridges deep into communities and layer on top and integrate with that the community assets, our strategies, our traditions that allow us to build our own capacity to achieve health and well-being. So I'm excited about those movements. I hope that they are nourished and I hope that they are sustained. And I look forward to working with partners, public and private, to achieve those ends. And thank you so much for just allowing me to come into the discussion.
Thank you so much.
Sandeep?
Okay, should I go? Okay. So I think for me, in closing, the important thing I see it as this is a very opportune time. There is a good opportunity because the system is shaken, to really make a significant change, not an incremental change in the system. And while we make that change, I think it's very important, to Alisha's point, and we completely believe that, to keep what is really good about the existing system, because not all is broken. There is a lot that is working. It has been working for so many years, and there is so much good that has come out of from the system, and it is coming out. So retaining those things, but also adding components which are around other modalities, around the workforce, particularly community health workers. I think even in India, we have seen what a fabulous role they have played during this time, and the opportunity again there to get them to integrate the community with the medical side today. So I think that's the opportunity that's there today, really, for us to tap in.
Modern health care has benefited a lot from science and innovation, no doubt. But it has also created a lot of inequity. And it is within that context of inequity that the workforce has to be seen and be discussed. For most health frameworks globally, the community health worker, who is really the entry point to health care, is still seen as an inferior health worker. He is not given that recognition in the continuum of care that is required. And until that one is corrected, there is no single country that is going to achieve what potential it should achieve. Remember that, especially for you, Denise, sitting in the country that spends the biggest amount of dollars per capita, but has much more inferior health outcomes than the small island of Cuba, that hardly spends anything compared to yours. But then, rather than looking at that objectively, we start getting into the ideology side of it. And I think that we have to make health and health workforce non-ideological and start asking ourselves the question, what is it that we really want to do? Right now, the health sector is driven by politics and economics. It's not driven by the desire to achieve the well-being as defined by WHO, not just the mere absence of disease. So if you create any innovation right now that cannot make profit, you will find it extremely difficult for you to sell it, even if it is going to make a difference to the people's health outcome. So that becomes then a major driver on what needs to be done where. Two, the inequities, we have lots of technologies that can bridge the inequities, but because they are not commercially viable, they do not say was still there in the US. If there was an election coming and you had politicians fighting to be elected, in any population in the world, would they elect a legislator who tells them that I will reduce diarrheal diseases in children by making you wash your hands and do ABC? Or will they vote for somebody who says, I will build the best specialist hospital here, bring ambulances, bring the highest trained doctors and the highest trained nurses? We would reward the latter and not the former. Because it's just not chic for you to talk about washing your hands so that you have reduced diarrheal diseases. Did you know that one of the most interesting side outcomes of the COVID pandemic in Africa has been a drastic reduction in gastrointestinal diseases? Why? Because hand washing and water became available. And that alone has saved millions of dollars in terms of expenditure in health, because gastrointestinal diseases are major causes of morbidity and mortality worldwide. So I would say this in conclusion, that you cannot discuss the future health workforce without agreeing on the future of health, because that is what should define the kind of workforce that we reward and we create. And unfortunately, right now, our vision of health is Boston area, big hospitals, big medical schools, big specialists, where everything can be done, and technology. The health workforce for the Boston area is quite different from what we would need in my village area here in Kenya. But then who wants to focus on what we need here? We are also focusing on reaching where Boston is at the moment. And I think that that is where we have a major problem. That workforce must respond to the vision. And that vision has to be different from what we have at the moment. Is that possible? Probably, but it will be difficult, because I would have hoped that coronavirus and the way that it has disrupted every step in our life would make us think different. But what happens? The moment we get 1 or 2 vaccines, all of a sudden we say that all those public health measures, we can drop them. We call them lockdown. We shouldn't call washing hands a lockdown, keeping a safe distance a lockdown. So even the language that we use for application of public health measures, a lot of which can be done by community health workers and don't require a chest specialist, that language itself is discouraging. So what we are seeing in the US and in Europe is that all of a sudden, once the positivity rate has gone down, you're saying, let's go back to business as usual. And that business as usual means then that even the workforce that we will be willing to pay for and willing to train and bring on board will be the one who serves business as usual. The community health worker in those circumstances is an endangered species. Thank you.
Thank you so much. That was great. I mean, you summed it up. We cannot go back to business as usual, and we should not go back to business as usual with regards to the lessons of COVID and the impact on the health system and workforce. I want to thank you all for bringing such really rich and fascinating insights from your countries and from your experiences to this conversation. And I wanted to let everyone know that in our final conversation, we'll bring together many of the learnings that we've gained throughout this journey. So please tune in for that. And I would like to remind everyone that you can follow this project on www.thefuturecenter.org. So the Future Center will have all of that information, including these beautiful Miro boards. And thank you again, Sandeep and Khama, for joining us and for being part of this conversation. And thank you, audience, for listening.
Thank you for
my pleasure.